And everyone is invited to type in their questions whenever they occur to them in the chat function.
Thank you very much, Katharina. It's a very, very kind introduction. So yeah, it's my pleasure today to talk about Wnt-mediated mechanism of diabetic bone disease. And for all of you who have been part of this webinar series, we know that we have already talked in depth about the fracture risk that diabetics have, also about bone imaging and cortical porosity. I think there was a talk on osteocytes from Kata and diabetes, so I think we already covered quite some topics. So I will keep my introduction rather brief, but nonetheless, I will introduce a little bit the topic, since there might always be some people who join our webinar series for the first time. So, where can I? Oh. Oh, okay, this is not working now. How can I switch my slides? I know. So we know that diabetes mellitus is characterized by chronic hyperglycemia. And in the case of type 2 diabetes, we have a very high prevalence, and the prevalence is continuing to increase. So in addition to corona, really diabetes mellitus is also considered a pandemic these days. And grossly, we divide into two types, although there are more clinical types of diabetes. But I think for most of us researchers, type 1 and type 2 diabetes mellitus are the most commonly known ones. And they have slightly different pathogeneses that in the end still both lead to hyperglycemia and diabetes. But in terms of type 1 diabetes, we have an early onset in childhood. And that is characterized by an autoimmune disease where the pancreatic beta cells are destructed. So that eventually leads into an absolute insulin deficiency. Whereas in type 2 diabetes, that is the more acquired form that develops during adulthood and is also much influenced by the diet and exercise. And here we have the insulin resistance that precedes the beta cell dysregulation and impaired glucose tolerance. But in the end, this might also lead to beta cell insufficiency. And as said, in both cases, we end up having hyperglycemia as the key characteristic of diabetes. So at a cellular level, hyperglycemia results in many different effects on cells. For example, there is an increased production of AGEs, of advanced glycation end products. There is also mitochondrial dysfunction that goes in hand with oxidative stress. There's excessive inflammation going on, endothelial dysfunction, and also impaired innate immunity. So many things that can affect the cell's behavior. And all of these cellular deficiencies in the end also contribute to the complications that we see in long-term diabetes, such as complications of the cardiovascular system, the eyes, the kidneys, the nerves, and of course also the diabetic foot syndrome. And recently, of course, we also have appreciated that the bone is a target of complications of diabetes. So on the one hand, we have the increased fracture risk, but on the other hand, also bone healing is slower in diabetics compared to healthy individuals. And here Peter Westergaard and also Richard already talked about this quite excessively, I think. But just to summarize here again, I think current numbers of the relative risk of hip fractures in type 1 diabetes is about 5-fold, whereas in type 2 diabetes, it's about 1.3-fold. So there is an increased risk of fracture in both subtypes. When we look at the bone pathology in diabetes, again, I have divided it between type 1 and type 2. Because in type 1, we know that these patients frequently have a low bone mineral density that goes in hand with this very highly elevated risk for fracture. Whereas in type 2, we really have this phenomenon of having normal, or most of the studies actually report higher bone mineral density and also increased fracture risk, showing that also bone quality aspects are very important in this context. And when we look at bone turnover, maybe we can start with type 2 diabetes, where I think it's quite clear that there is a low bone turnover state. So this has on the one hand been shown in some studies that used bone biopsies and histomorphometry, where at a local level a reduced bone formation rate was seen and also a reduced number of osteoclasts. But also at the systemic level, looking at bone turnover markers, most predominantly P1NP and also CTX, often they show reductions, although in my opinion, looking at many studies, I think CTX is not always as consistently low as the bone formation parameters, and in some studies you actually also find unaltered levels, sometimes even higher levels. So yeah, in type 1 diabetes, there are very few studies that looked at bone biopsies, so there are a few with very low numbers. And those few studies actually have shown no difference in bone formation or bone resorption. However, I also put a question mark there because I really think that more extensive studies are needed to really address this properly. And at the systemic level, again, bone formation rate is very significantly down, whereas again, at the bone resorption level, the data are a bit conflicting, showing low levels or high levels, depending on which study you look at. So because the inhibition of bone formation is such a prominent feature of diabetes, we
working with us, and the team needs to really engage in a conversation from start, maybe with those topics. So it's to highlight.
Can you mute yourself, please? Okay, cool. Yeah, so because the inhibition of bone formation is so profound, I think there is a good point, of course, to look at also Wnt signaling. And here, again, there is for diabetes in general, we see that the increased inflammation, the increased ages, the increased reactive oxygen species, all could contribute to the impaired osteoblast formation and increased adipogenesis. And in this graph, although it's actually not too old, it's from 2015, the Wnt signaling pathway was not really considered in here, which I thought was surprising. But of course, we know that also transcription factors like PPAR gamma are increased that support adipogenesis, whereas BMP signaling is decreased. So let's say contributing to the inhibition of osteoblast differentiation. But I think really today the question is also how Wnt signaling is part of this differentiation process of the MSCs. So just a very short introduction to Wnt signaling. So I'm sure you all have heard about it before, but it's a really important pro-osteogenic signal. On the one hand, it stimulates osteoblast differentiation and function, but at the same time, it also indirectly inhibits bone resorption by inhibiting osteoclasts. So it's a very potent anabolic pathway for bone. And for Wnt signaling, we have the phenomenon here that if in an unliganded state, we have the beta-catenin, which is one of the key transcription factors for for Wnt signaling, that it is constantly being degraded in the cytoplasm by this destruction complex. But once a Wnt ligand binds to the LRP5/6 co-receptors and the frizzled receptor, then this destruction complex is dissolved and beta-catenin can accumulate and go into the nucleus and then induce target gene transcription. Because Wnt signaling is such an important pathway, not only for bone, but for many, many other organs as well, it is very tightly regulated. And thus we also have several Wnt inhibitors, such as sclerostin and Dickhoff, which directly target the co-receptors. Maybe I'll get back my laser point. Target directly the co-receptors, but we also have some inhibitors such as WIF1 or SFRP that directly bind to the Wnt ligands and thereby prevent it from binding to the receptors. So multiple levels of regulation of Wnt signaling. Interesting, I cannot proceed if I have this marker. Okay. Yeah, here's just a schematic showing again what we've briefly seen before, so that Wnt signaling, in fact, is also an important signaling pathway for the determination of the mesenchymal stem cell will go into an osteoblast or an adipocyte. And here again, we see the BMP signaling pathway that also pushes towards osteoblasts, similar to the Wnt signaling pathway. And opposing to those two pathways, we have PPAR gamma that really pushes adipogenic differentiation. So let's have a look now at Wnt signaling in diabetes. So this is really a mix of type 1 and type 2 diabetes, whatever I have found practically in terms of studies. And the first study I want to show is this one. It's in type 1 diabetic mice. And I think it's important because it's one of the few studies that actually directly looks at the regulation in bone tissue. Because later we will see that many studies that look in patient cohorts, for example, oftentimes look at the circulating levels, but it is important to look at the bone levels as well. And here they have isolated RNA from the bones of type 1 diabetic animals. And in the upper graph, we see that if you focus on the black bars, that many typical osteoblast markers are downregulated in the diabetic state. And if we look down here, then we also see that beta-catenin, for example, is very much decreased. And at the same time, we have a marked induction of sclerostin and DICOP1, which we already have introduced as important inhibitors of Wnt signaling. So besides this study, there are also some studies that have shown that, for example, Wnt1, Wnt5e, and Wnt10b are downregulated in diabetes. And there are many more studies that confirm that DICOP and sclerostin are upregulated. Before we go into the Wnt inhibitors, which will be one important aspect of this talk because most studies have been dealing with those two inhibitors, I would like to show this relatively new study from one of our FIDELIO members, Professor Napoli, on LRP5 gain-of-function mutations. So here they have crossed an Ankita mouse, which is a mouse model for type 2 diabetes, with a mouse carrying this gain-of-function LRP5 mutation that leads in this high bone mass phenotype, and have investigated whether activation of Wnt signaling can abrogate bone loss or bone insufficiency that is seen in this Ankita mouse. And they have done this at 2 time points, so at 6 weeks when the hyperglycemia starts, and at 20 weeks of age when the hyperglycemia has persisted already for a while. And if you focus on the blue and the red bars, then you can see that there's no difference in the high bone or in the bone volume between the control high bone mass mouse and the diabetic high bone mass mouse. So proposing that really if you activate Wnt signaling, it is beneficial for a diabetic bone. Another finding that was quite interesting, and I'm going to make a short excursus here into how also Wnt signaling can affect glucose metabolism. So even though we mostly in the talk want to focus on how diabetes affects Wnt signaling, I just want to also point out here that Wnt signaling per se also can influence glucose homeostasis. And so here's in their study, they also have shown, if we focus here on the Ankita mouse, that is the, let's say, wild-type diabetic mouse developing here at the age of 6 weeks, approximately hyperglycemia. But we see here for the crossed mouse with Ankita high bone mass mouse that the onset of diabetes is somewhat not so steep. And if you quantify this in a different way here, then here if you look at especially the 6-week age group, you see that while the Ankita mice are already hyperglycemic, the high bone mass Ankita mice are not. And this is again just quantified here. So really showing that activation of Wnt signaling leads to a delayed onset of diabetes. And I just want to show a few more studies that support this concept. So here is one study from many years ago where they looked at glucose parameters in LRP5 knockout animals. So these animals then are loss of function and osteopenic. And also in this case, again, you see that these LRP5 deficient animals have impaired glucose tolerance. Now you might ask, is this only a phenomenon in mice or also in humans? And in fact, there was a study from a Finnish group from Uti Mikiti where they looked at humans with LRP5 loss of function mutations. And here they had 12 subjects with these loss of function mutations, and they of course had very low bone mass and multiple fractures. And at the same time, it turned out that 6 of them had diabetes and 1 additional person had glucose intolerance. So they then looked into this further a little bit and did more sophisticated tests, and in the end found that many of these patients had impaired beta cell function, although insulin resistance was not detected. And finally, just to finish off this section, here are the data from sclerostin knockout animals, where we again have activated Wnt signaling, if you like, and they show reduced fat pads, but in the end also show increased insulin sensitivity. So there definitely seems to be something going on, that Wnt signaling and activation of Wnt signaling can impact on glucose homeostasis. So that might have additional beneficial effects of in the context of diabetic bone disease. In addition to that, it should also support the bone structure and bone homeostasis, but at the same time, it could actually also somewhat improve the diabetes parameters. So now I would like to come back to, again, how diabetes impacts on Wnt signaling. And now we're going to look into sclerostin first as one of the Wnt inhibitors. And there has been one study from Italy, again, that showed that only type 2 diabetics had increased levels of sclerostin, whereas this was not the case in type 1 diabetes. And that was also recapitulated by a study from a Greek group, where they also found this increase of sclerostin in type 2 diabetes. However, there are more studies that show contrary results. So again, one study from 2017, where they looked at type 1 diabetics, and here you can see that both sclerostin levels and DCOP1 levels were increased in this cohort. And this was also found in a different study from 2014, where also elevated levels of sclerostin were found in type 1 humans. So I think probably also here more prospective studies are needed to really discriminate more between the severity of diabetes and also medications that they have taken, because the data at this stage are still quite inconsistent. A very important study, I think, was also published this year again by Nicola Napoli's group, where they again also looked at sclerostin regulation in diabetics in type 2 diabetes. And they also have seen higher circulating levels of sclerostin in this patient cohort. But I think more importantly, and why I think this study is so important, is they also showed at bone tissue level that sclerostin was increased. And I will come back to this point at the end a little bit again to just highlight again why it's important also to look at bone tissue levels of gene expression, not only circulating levels. So I think in the end, most of the studies seem to point towards increased levels of sclerostin, and I think that it's also increased in bone directly is a good rationale to really target this protein and try to get rid of it, so to say, so you can improve bone mass in that diabetic situation. And yeah, this is what we have done in rats many years ago, I think 10 years ago, meanwhile. So we have used initially the ZDF rat, which has a leptin receptor mutation. So the rats just don't stop eating and become obese and then develop diabetes. And as you also might have come across, most of the animal models are not really great in terms of recapitulating the BMD that we see in humans that is rather high, but actually they often have low bone mineral density, as you can also see in this graph here. And also, if we look at the bone turnover markers, we see that I think the good thing is that they do have this quite profound suppression of the bone formation markers, which is what we also want to target, but they show quite a stark increase in bone resorption marker CTX, which might also explain why we do see this decrease in bone mineral density. So these diabetic rats were then treated with a sclerostin antibody. And I think here in these cross sections, you can see very nicely that the diabetic animals, first of all, have a lot less bone than the wild type control animals. And also you can see that the treatment with a sclerostin antibody is very effective in increasing trabecular bone mass, but also increasing the cortical bone as well. Here, if we look at histological level, again, in this von Coster stain, you can see in black, the bone is depicted that the diabetic animals really gained a lot of bone in this time. And also in the calcium double labeling, you can see that even though there's barely bone formation going on in these diabetic animals, that it can really nicely be increased by applying this antibody. So it seems to be a quite effective therapy to treat diabetic bone disease. And this is not only true for type 2 diabetes, but here there was also one study done on type 1 diabetes, where essentially you see the same effect. So here, very low trabecular bone, but if you treat these diabetic animals with the sclerostin antibody, then you can improve bone mass. So I also would like to show some more studies on parathyroid hormone, because you all will know that this hormone is also used as one of the very, very few bone anabolic therapies that we have. And downstream, however, if we consider the actions of PTH, it goes along the lines with sclerostin inhibition, because it negatively regulates sclerostin. So that's why you can consider, let's say, that maybe treatment with PTH should give similar results to the antibody treatment. So we also have investigated this in the ZDF rats, and it was quite interesting that the effects were not really all that comparable with the sclerostin knockout animals. So first of all, what we do see here is that in the spine, there was an increase of the BVTV, of the bone volume, after PTH treatment in the diabetic animals. But if we look at cortical thickness, for example, at the cortical bone, there was no increase whatsoever. So it was not very effective. And again, if we show here bone histomorphometry, again, we see a bit of an increase with PTH, but really not that much in the diabetic animals. And we do see an increase in bone formation, here again, shown with the calcium labeling, but it is not quite as pronounced as it is in the wild type group. So there seems to be some kind of partial resistance to PTH. And I think this is even more seen in the biomechanical tests, where we have done the 3-point bending for the femur and the compression test. And really interesting in the femur, I mean, the outcome after PTH treatment was even worse in these rats compared to the wild type animals and compared to the non-treated diabetic animals. So clearly, PTH does not seem to be so beneficial, at least not for increasing cortical bone mass in these animals. And we have then continued to look into what the explanation could be. So we have done some cell cultures with osteoblasts, where we treated them with intermittent PTH, high levels of glucose, or a combination. And you can see both in the mineralization status and the calcium phosphate ratio that first of all, there is a quite profound suppression of mineralization in the high glucose treatment group, but the combination of PTH is by far not as or able to really get up to the levels of control treated cells as like the non-high glucose treatment group. So we looked into signaling a little bit, and PTH is known to very rapidly stimulate cAMP production, and then PKA, CREP, and CREP then is the transcription factor that activates target genes. So we looked at cAMP induction after different concentrations of PTH. And whereas in the control cells, there was a very nice dose-dependent induction of cAMP, this was not at all the case in the glucose-treated osteoblasts. So there definitely seems to be some interference of PTH with the glucose, although we haven't really followed up on this. I did find another quite recent study that looked into this a little bit in a type 1 diabetes model again. So I thought that was quite interesting, because here again you see, similar to our type 2 model, that in type 1 diabetes, the PTH is not very effective in improving bone volume. And they then have looked into beta-catenin expression in the bone tissue, and have found that it is, first of all, again, very much decreased in the type 1 diabetic group, but then it remains low after PTH treatment. So it's not able to push this higher. So this group has then produced a mouse where they can selectively activate beta-catenin in osteoblasts using the collagen promoter. And they have then subjected these animals to type 1 diabetes and with or without PTH treatment. And what you can see is here, looking at the bone volume, if we look again at the purple dots, that if you activate Wnt signaling and treat with PTH in diabetic animals, then you can still improve bone mass compared to, let's say, the type 1 diabetic animal with PTH treatment, where again we see no effect. So activation of Wnt signaling seems to be very important and actually a prerequisite for PTH to work in these diabetic animals. Okay, so moving on to DICOP, the other Wnt inhibitor that we're going to have a look at. So I think I already showed one slide earlier that DICOP levels seem to be increased in patients with type 1 diabetes. And here's again the study from the Greek where they look at different Tanner stages. So this is like pubertal stages for the children, more or less. And you can see here in the summary plot that DICOP-1 levels are increased compared to non-diabetic individuals. And as I pointed out earlier, here we have the same slide again, that DICOP is increased in type 1 diabetic patients. So this again seems to be, at least for type 1 diabetes, quite consistent. And I also found one, again, quite recent study where they looked at circulating DICOP levels in type 2 diabetes, and again found an increase of DICOP levels as compared to the controls. So we also have looked into this, into the role of DICOP in diabetic bone disease. And we have chosen first to start with the type 1 diabetes model, have used the streptozotocin injection, and also could see what is seen in patients also is that we have this increase in circulating DICOP levels. So we then went on to delete DICOP-1 in late osteoblasts and osteocytes using the DMP-1 CRE. And the reason why we took this CRE line is actually a really technical one. So originally we wanted to take the Osterix CRE mice because we know that that is more significant in terms of the circulating DICOP-1 production. But since it's inducible cell line with doxycycline, we found that the doxycycline interfered with the streptozotocin. So we couldn't get useful data, and then decided just to take the DMP-1 CRE, which is a constitutive DICOP-1 knockout mouse. So we didn't have any interferences with tamoxifen or doxycycline. So anyways, looking at the data of this DICOP-1 knockout model, what we see again, first of all, is a nice decrease in bone volume in the diabetic animals of the wild type or the CRE negative mice. But when we look at the CRE positive mice, we still saw a significant reduction after diabetes. But if you look at like how much these animals lost, they lost a lot less bone as compared to the CRE negative controls. What was quite interesting is that the trabecular and the cortical compartment seem to act a bit differently. So if you looked at the cortical compartment, there was really no bone loss whatsoever in the DICOP knockout animals as compared to the CRE negative control animals. And you might think that if you knock out DICOP, the main effect would be by increasing bone formation, but this was actually not the case. So if we look here just as at P1 and P as one of our markers that we looked at, of course, we also looked at histology and it showed the same results. We see a quite profound suppression of bone formation in both models, so regardless if DICOP-1 is present or not. But since it also has been shown by us and many others that DICOP via the osteoblasts can stimulate osteoclastogenesis, we also had a look into osteoclast numbers, and it was quite intriguing, I think, for us to see that while type 1 diabetes, at least in the mice again, leads to a quite profound increase in osteoclast numbers, this was not the case in the mice that were lacking DICOP in the late osteoblasts and osteocytes. So showing that even though the deficiency is in the osteoblasts, it's really a communication to the osteoblasts and the lack of their induction that prevents or ameliorates the bone loss in type 1 diabetes. So at the end, I just want to finish off with two, I think, important messages I also want to bring across. So the first one is about the location, I called it, because I think it's really important, especially considering morphogenic pathways such as Wnt signaling. As I said in the beginning, where to look at, what does the circulating levels of a Wnt inhibitor, for example, mean? And I want to exemplify this with two examples. So the first one is on DICOP, because we just have the most experience with this protein. So it's just some insights from our data. So here we have knocked out DICOP in many different osteogenic cell types or lineages. And the first one that we also have done is to knock out DICOP globally using the ROSA 26 ERT2-CRE. And okay, here you see the increase in the bone volume, which is to be expected, and you also see very nicely decreased serum levels of DCOP1, but also skeletal levels of DCOP1. But then when we looked at the Osterix-CRE and the DMP1-CRE, in both cases you can see an increase in the bone volume. But if you look at the serum levels, only in the Osterix-CRE was reduced, whereas the DMP-CRE did not show an alterations of the serum levels of DCOP. However, again, if you look at the bone tissue, you do see this reduction of DCOP in the bone. So this means that the circulating levels of DCOP here do not necessarily correlate with the bone phenotype that we see up here. And most likely, it's really more important what is going on in the bone tissue than in the circulation. And that's also why I pointed that out first in the sclerostin study in the humans, why I think it's so important that Nicola has made the effort to look at sclerostin levels in bone tissue itself, because I think for bone, in the end, it's a much more important information than looking at circulatory levels of sclerostin. And the second example I want to show is OPG. So I'm sure you all know that OPG is also a critical antagonist of rank ligand actions. And in this study from the group of Charles O'Brien, they have practically found similar things. So here they have knocked out OPG either again globally or using the DMP-CRE. And in both cases, you see that there is a nice reduction of the bone volume. However, looking at serum levels of OPG, it was only reduced in the global knockout, but not in the DMP1-CRE. But again, looking at bone mRNA levels of OPG, it's decreased in both. So again, this shows that practically circulating levels of some proteins do not necessarily have to correlate with the bone status. So just, I think, for the future to consider this also when you think or look into papers or think about your own data. The other thing I just wanted to mention about DCOP is that maybe some of you might have wondered why DCOP antibodies never made it into clinics, not the same way as sclerostin antibodies have, or why in the end the anabolic effect of DCOP is not as strong as that of sclerostin. And the reason is that many Wnt inhibitors compensate for each other, and in particular in the case of DCOP, something that we also have seen always is that if you have a deficiency of DCOP, then sclerostin levels are increase in a compensatory manner. And I think many studies have shown this meanwhile, but this is just one to exemplify this. And very nice study also performed in 2018 that shows again why DCOP inhibition alone may not be so successful based on this compensatory increase in sclerostin was this one here. And here they have again created knockout animals of DCOP1 or sclerostin, again using the DMP1-CRE. And what you can see here is that whenever, so here, for example, you have the DCOP knockout alone. So you see, okay, there's increase in bone volume, but not that much. With sclerostin, it's already a little bit more. But here, if you have a double knockout of sclerostin DCOP, then you really get very, very strong anabolic actions. So, and that's, of course, also one of the rationales that Amgen has taken forward in this Nature Communication study, where they developed these bispecific antibodies against sclerostin and DCOP. And of course, it would be expected that, or it was shown also that it has really superior effects in turning on bone formation as compared to either of the antibodies alone. Okay, so that was already it from my side. So here, just as a take-home message slide. So I think all of you by now know that patients with type 1 diabetes have a low bone mass and an increased fracture risk, while patients with type 2 diabetes have a high bone mass, but still an increased fracture risk. I think we can, let's say, generally say that diabetes seems to be associated rather with a low bone turnover state, although I think for some, especially type 1 diabetes, this might still need to be confirmed in future studies. But what we, I think, also clearly have seen in many studies is that Wnt signaling is suppressed in diabetic conditions, and that activating ring signaling seems to be a promising approach also to treat diabetic bone disease. Yes, with this, I just want to thank the lab for all the people who contributed to the studies that I presented from our group. And then, yeah, just for all the people who are missing traveling, just some nice pictures from Dresden. Yeah, hopefully we can all travel again soon and see beautiful cities and nice people. Yes, thank you very much for your attention.
Thank you so much, Martina. This was an awesome talk. Thanks.